We'll start the talk. You want to pull your slides up, Ashok?
Yeah, will do.
So, good morning, everybody, or good afternoon, evening, if you're from elsewhere. Thank you for joining us today with a really good friend, Professor Ashok Seth. Ashok, as you can see, I'm not going to read all his titles, but he's really one of the most important, well-known interventional cardiologists in the world. He's been really at the forefront of coronary and structural intervention. I was actually with a friend last night, Ashok, who is my rep for Medtronic core valve. And he said to me, who's the speaker tomorrow? So I said, well, actually, you don't know this. You work for Medtronic, but it's the person who implanted the first core valve in a human in the world. Really? So yes. Ashok has a huge experience both in structural, and it's really an honor for us to listen to you today, Ashok.
Thank you very much. Thank you, Azim. Great to be with you. I mean, there's such fond memories, and I've always not just been, just admired you as a friend, but admired you as an innovator, as a scientist, an expert interventionalist. And so it's just good fun. And then one sitting there, I mean, that's just a twosome. So I think this is a great one for me, I would say, to be with you. I'm going to talk about PCI of severely calcified lesions. And for those of you who are there, I'm going to make my talk very practical, going to be less didactic. I know the attention span is short when we're on the virtual platform. So it would be a case discussions. Here are my conflicts, as you can see here. So I'm in some way or the other linked to some of the devices that we're going to talk about for treating severely calcified lesions. I want to also point out that we're starting one of the largest real life registries of shockwave, 1,000 patients, real world patients in India, of which I'm the principal investigator, and the first case gets enrolled in 15 days time. Now, wow, this slide came in at the wrong moment. So let's just see. Calcified lesions. Now they truly constitute 25 to 30% of our practice, especially as patients get elderly, they're more diabetics, patients who had previous bypass surgeries who need revascularization, and of course, diffuse disease. And this constitutes, but if you look at the severely calcified lesions, which is truly the nemesis of interventional cardiologists, the ones which we dread is 8 to 10% of these lesions. And clearly, these are lesions which are more prone to failure, stent delivery, dissection, perforation, stent under expansion, which are the procedural problems that we face. And of course, in the longer term or in an intermediate term, they have poor outcomes with increased thrombosis, both the early and intermediate, as well as restenosis over the next year. Of course, over the last decade, I'd say we've got more dedicated tools for calcium modification, cutting balloons, scoring balloons, atherectomy devices. More recently, the intravascular lithotripsy, which got approved in the United States a few months ago, the OP and ultra high pressure balloons. But clearly, we need to understand the use of these devices. And perhaps in many instances, these are not competitive, but complementary in use. And of course, there's an increasing understanding of calcium by intravascular imaging to define the extent of calcium, to strategize and choose the right modality of treatment, to optimize the results for the best outcomes in intermediate term, but more importantly, to understand that it's also for the safety of the procedure and the patient. Now, some of the technical considerations, and again, this is aimed at fellows, that you really, for severely calcified lesions, it's very important to have good guide catheter support, 7 French supportive guides, not just allow you to, not just provide you the support, but would also allow passage of devices and any bailout strategies should they be needed for any complication. So that's important as far as the guide's concerned. Wires, yes, but often you see poor guide catheter support related to the fact, and if you want to improve on the guide catheter support, of course, one does need extra support. Wires, example for Grand Slam in tortuous anatomy and tortuous iliacs, long sheets are great. And when we talk about delivery, which is difficult in tortuous calcified anatomy, clearly guide extension catheters should be available. A regular use of buddy wires to get devices down, either or. And then, of course, lesion modification tools have become increasingly important. But the single most important lesson that we've learned over a period of time is do not implant a stent till the lesion is fully dilated. And I would add to that is in 2 orthogonal projections, not in just 1 orthogonal projection, because as recently as a month ago, me myself, after 35 years of interventional cardiology, still went ahead and implanted a stent by looking at a lesion in one view. And when I went to the other view, it was totally underexpanded with eccentric calcification. So I think that's a very important aspect to understand. Now, we've got a variety of tools to deal with calcified lesions. We have it on right here, laser. We have the balloons, the specialty balloons, like the cutting and scoring balloons. We have the OP and ultra high pressure balloons, which may not be available in the United States, but are clearly are available in Europe and Asia. We then have intravascular lithotripsy, and we have the atherectomy devices, the orbital and rotational atherectomy. And of course, we have a variety of imaging tools, mainly IVUS and OCT. I'm not going to discuss with you about the various pros and cons and issues. You've been through that. You probably understand that very well yourself. You've had lectures devoted to both imaging as well as various devices. I think all I'm going to say around all this is that perhaps OCT offers us better quantification of the calcification, which fits into many of our algorithms that have been developed to quantify and therefore strategize on the right mode of therapy for a very severely calcified lesion. I think I'll just dwell on this slide to understand one aspect of it, that the mechanism of stent expansion in calcified lesions gives you the perspective when you define severely calcified lesion by imaging and then decide on strategies, especially when I talk about complementary tools and strategies. And of course, if you even if you have a circumferential calcification and it's thin, one can expand it with non-compliant balloons or ultra high pressure balloons, break it, and still get a circumferential expansion and a good MSAs. Obviously, you can have an eccentric calcium, which is thick, and you can get a good lumen. You can have a concentric calcium, which is thin, and you can still balloon dilate it and get a good MSA. But the problem becomes when you have concentric or greater than a 270-degree arc of calcification, along with a thickness which is 0.5 millimeters, more than 0.5 millimeters, and clearly getting up to 0.6 or 0.7 millimeters, that one has the biggest challenges. And of course, that's been well exemplified by Fujino and Akasaka. A 4-point scale, you well know of this, so I'm not going to again go through this, but just to make you understand that this rule of 5s is very valuable when imaging heavily calcified lesions. And again, this is I would rather go to the cases, but maybe this I can talk about. See, this is, I think, again from Fujino, who looked at this and looked at it by the retrospectively. And this is retrospective data which has not yet been put into prospective evaluation to look at longer term outcomes. But in a sense, what fitted in with that retrospective data analysis was the fact that if you had the calcium scoring, which was based on the arc of calcification, as you saw in the previous slide, which was based on the depth of calcification greater than 5 millimeters, and which is based on the length of calcification, each having a score apart from 1 point, apart from greater than 180 degrees arc, which had 2 points. And if you had a score of 2 or less, you could actually still get away with non-compliant balloon angioplasty, a high pressure balloon angioplasty, and stent implantation, with an expansion being achieved in 99% of the patients. Again, if you had less of an angle, but still a thick calcium, that was a 1 point, and expansion, adequate expansion or optimal expansion was achieved in 97%. But again, if you had a huge arc of calcification greater than 270 degrees, which was thick calcification, optimal expansion could only be achieved in 68%, which means 32% remain underexpanded in terms of the final result. While these are the tools we use regularly for severely calcified lesions, I'm not putting this slide up to compare these devices. All I'll say is that these devices are complementary when you start getting into real life severely calcified lesions And this is what I'll demonstrate to you. Across the world, there's been a variable use of intravascular imaging, even though we realize and emphasize it's important in severely calcified lesions. And you've known that yourselves. There are centers which do a lot of imaging, perhaps 100%, and there are other centers which remain at 10 to 20% imaging. I think there's a balance which has to be achieved from across the world. There's no question in my mind that severely calcified lesions, the ones which we talk about, it's upfront intravascular imaging which helps to strategize, which helps to actually formulate the next step, and which therefore results in optimization as well as safety for the patient. However, for mild to moderate calcification, in my category, mild to moderate calcification, it's fair enough to use what I called a non-compliant balloon test, a near optimal sized balloon. For example, a 2.75 millimeter balloon in a 3 millimeter vessel going up to 20 atmospheres. If the lesion gives way, we just move along and stent it. But of course, if the lesion doesn't give way, I would emphasize the need for intravascular imaging, understanding the vessel, and then moving up to the other tools that we actually have, which could be either ultra high pressure balloons, but more importantly, it could be atherectomy or intravascular lithotripsy. For smaller vessels, 2.75 or less, I favor as a single tool rotational atherectomy, primarily because I know that I would get the cracks into the lesion, maybe up to the media, and be able to implant a stent adequately. But for vessels 3 millimeters and above, I clearly favor intravascular lithotripsy or rotational atherectomy plus lithotripsy to get to the deep calcification. But that again is what imaging tells us. Now, just a throwback in time, cutters, dillers, scraper, burners. Actually, this is a cover from one of the first manuals of interventional cardiology, which came out in 1990. And at that time, obviously, balloon angioplasty was getting less favored, and these drillers and cutters and scrapers and burners, the laser, the atherocath, the tech device, and of course, the rotational atherectomy was clearly becoming our flavor of the year. And all of us imagined ourselves to be rotodocs. At that time, I think I started rotational atherectomy in 1991, so that's 30 years anniversary of rotational atherectomy. And in those days, it was a standalone device in lieu of balloon angioplasty when stents weren't there. And of course, now we have this as a most important tool for calcified lesions. And I just go up front and say, if you think you need rotational atherectomy, then do it, use it, learn to use it, and that's important. Now I'm going to get into more and more complexities, from simple stuff or more moderately simple stuff. I'm going to move to fairly complex stuff. But that's defining how we approach severely complex lesions in the real world. We need to understand guidewire bias when we use rotational atherectomy. Clearly, this guidewire bias can be advantageous in such situations where one could actually ablate eccentrically, maybe even ablate nodules, and therefore have a much larger lumen than one would have had otherwise in a straighter segment. On the other hand, one must also understand that on angulated lesions, the guidewire bias may also result in perforation or deep cuts into the close to the adventitia. And that usually happens in such situations as a diagonal branch or in a curved tortuous anatomy. So one's got to be careful of that, and therefore understand how we modify our practice when you get such scenarios. For example, here's a very tortuous calcified left anterior descending artery, LAD seen in two views, and you can actually see that. So it's not just anterior posterior that it actually changes direction. It also changes direction side to side. So there are a number of, I'm surprised that this isn't running, but you saw that. Now, I start off with a 1.5 burr, but obviously you can see that the 1.5 burr is going to go close to the adventitia. The wire is going to it's the guide wire bias, and this is how the 1.5 burr is actually traversing. 2 minutes of burring told me that this is enough unless I want to perforate this vessel. The risks of perforations are high, and therefore downsize to a 1.5 burr, being careful that you just don't drop speeds. You actually go across those curves gently. It still takes a straight path, as you can see, but it's still not going deep and hitting the calcified curves and bends, and therefore one is able to have a much greater ablation than you would have had in a straight vessel. Even a 1.5 doesn't need to be followed by a 1.25. 1.25 doesn't need to be followed by a 1.5, and we still have great MSAs, a very good result. And then, of course, was followed by the rotablation of the diagonal, again with implantation of 2 stents and a good result. But how do you actually take this into real life learnings? You can actually see here a circumflex which comes off, and in circumflex ostia, rotational arthrectomy has to be done extremely carefully. Again, because of those biases that you can see with the wire here, you can actually see what we call a grooving of the ostia of the circumflex. The wire, the burr seems to go totally, it appears that it's going out of the ostia. It's away into the, away from the lumen, but it's actually going through the media, as you can see, and this causes what we call furrowing or grooving of the vessel. You can actually see that. You can see a groove forming, which seems to be away from the lumen. And of course, that means that you've actually close to the adventitia. This is where one's got to be careful. One cannot go up on the burr size. One's already got a good lumen out here, and therefore this calcified area would be easily amenable to stent implantation with good MSAs. Now, how does that relate to this? Now, this is an important aspect. 84-year-old gentleman referred to me for an ACS, STT changes, ongoing chest pain. He was on inotropes and intra-aortic balloon pump at another center. He's known to have chronic obstructive airways disease and chronic kidney disease. His ejection fraction is low. He's got moderate MR, and an angiogram done outside in the other center demonstrated heavily calcified LAD occluded right coronary artery. Of course, and I'll just show you that I actually put this gentleman on Impella CP because he had only a single vessel left, and that is his LAD. There's no circumflex. There is a large intermedius, as you can actually see there. But this LAD is the most tortuous and most heavily calcified vessel I've faced for a long, long time, perhaps in my career. Anterior, posterior, side to side, ejection fraction 30%. Now, here's the algorithm which has not been discussed. And when we go into real life complex cases, we need to create algorithms out of our own experiences. For example, I did get a rotor wire down this after sort of 10 to 15 minutes of getting one wire down, trying to get a microcatheter down. Couldn't get a microcatheter down, but still wedged the microcatheter in, got a rotor wire down. And then I went with a 1.25 burr, and you can actually see here what the 1.25 burr does. There's no way that a 1.25 will ever cross those angulations and tortuosities, which are heavily calcified. You can see on the right frame what the burr is doing. It has to go out of the vessel to traverse anywhere rather than inside the vessel. This is 5 minutes of burring. What do I do next? So here's the algorithm for that. It's well recognized that upsizing the burr in some cases, not this one, may actually help you greater than taking a smaller burr. And that's because the larger surface area of burring may actually get through to a lesion which you spend much longer burring with a smaller burr. The second aspect is change the wire. From a rotor floppy, one goes to a rotor support, therefore changing the biases of the wire. So that's the second thing one can do. I actually do the first step after a 5 minute of burring, where the burr can't go across, is change the burr. Not because the burr diamond crystals are getting abraded. It's just that they may get filled up with the debris, and therefore the burr gets smoother, just like a sandpaper can get smoother. It's a good idea to change the burr. But then you can do these, but there's also others. NC balloon, move that calcium which you're hitting all the time with a non-compliant balloon. If you can, just change that. You can actually use a laser to create a small niche. And remember, the laser is a very poor tool for severely calcified lesions. Apart from perhaps you may make a small area where your rotor burr centers around rather than hits the calcification eccentrically. And of course, you've heard of granuloplasty, which you actually do for CTOs, where you burst small balloons to create space for crossing the lesion. This is the algorithm one uses, and this is the algorithm where therefore one goes into this case where I actually then went in and ruptured 7 balloons, I think, 6 balloons at high pressures into the lesion because the lesion was uncrossable with a balloon. And gradually got a couple of millimeters into that lesion with 0.8, 1.1, and 1.5 millimeter balloons. After 6 balloon granuloplasty, still, of course, the lesion wasn't crossed. Another 10 minutes of burr time with a new rotor burr helped to actually cross that lesion. By this time, I think the rotational time was actually close to 20 minutes. Now you'll see that the burr passes nicely. And of course, then I move up to, at this present moment, I would then, after the 1.75 burr, which again took 5 minutes to ablate through all that, we would now, in our present scenario, use intravascular lithotripsy. But then in that scenario, we just went up, implanted stents, had a great result on that LAD. We lost that branch initially. We got that back subsequently. The patient did good only because he was on an impeller. This was his last remaining vessel. This was a 4.5-hour procedure. We had the impeller in for the next 3 days because his left ventricular was stunned. His ejection fraction had come down to 20%. And by 4th day, we removed the impeller and then he went out of the hospital. So I think we need to have algorithms from experience beyond the usual algorithms that we see. And you're going to see some more of these. For example, this is what you commonly see, undilated lesion, and yet from another center, an operator implants stents. It happens to all of us, but we must take care that we can't implant stents into undilated lesions. This patient had undilated lesion and still had 3 stents implanted into this vessel. And that was the final result you see with a high-grade residual stenosis. Comes back to me, he comes to me 8 months later with the worsening angina. He also has a circumflex lesion, which is heavily calcified. At that stage, in the absence of IVL, and I just want to emphasize the role of IVL, there are 2 layers of stents out there. You can actually see there were 3 stents in this vessel. There is still concentric calcification and underexpanded stent, which is 2 layers of it. In our present scenario, we would actually use IVL shockwave. And by the way, inside the stent, which is an off-label use of shockwave, the success rate of getting optimal expansion is approximately 70% in real life. It is much lower than de novo calcified lesions. But a combination of shockwave and ultra-high pressure balloon can still expand these lesions. And I've got some cases around that. This case was done with an ultra-high pressure balloon. I know they're probably not available in the United States, but these are double, and Azim has a great experience around these. These are double layer balloons which go up to 35 to 40 atmospheres. Their expansion characteristics are more or less similar to a non-compliant balloon, except that the non-compliant balloon have rated bursts of 22 atmospheres, and this has a rated burst of 35 atmospheres. And of course, there are safe balloons to use because they don't continue to expand. For example, a 3.5 millimeter balloon would end up with a 3.8 at something like 35 atmospheres. And they don't dog bone, therefore, so create importantly pressure at the point of which is not dilated. And so that's what we went up. 45 atmospheres on that lesion. The lesion gave way despite 2 layers of stent there. And we completed that task with a great MSA in that vessel right up to the ostia. And we actually had this final result on the right. But the left, we must remember, was also calcified, the circumflex. The left shows that it's again napkin ring calcification. Good one for IVL, good for rotational atherectomy, but a 1.5 bar does not do much to this. I should have checked it up on IVUS, what had the 1.5 bar done to it, because it still remains constrained as the non-compliant balloon goes in, and you can still see that it does not open after a 1.5 bar. We move to a 1.75 bar, and after a 1.75 bar, the non-compliant balloon doesn't open it. So we have the OP and ultra high pressure balloon, and the OP and ultra high pressure balloon gives way at 40 atmospheres, as you will see on the right side, but opens up the lesion at that very point. And then we actually have a very good result without any perforation of the vessel. So many of these techniques are complementary. What we need to certainly understand is that the more we image, the more we will actually realize what next tool to use. I could have actually used at that stage of a 1.75, which I saw hadn't fractured it. In the present times, of course, we would use an IVL. I could have gone up to a larger burr before going up to an ultra high pressure balloon. You could see that I didn't even break that lesion, the circumferential calcification state. I hadn't broken into that. IVL, well, introduced it, you have it now. I introduced it to India in my CHIP CTO meeting in January of 2020. And I think I urge you to read up this, editorial of mine in the CCI just a couple of weeks ago, which looks at real world experience of intravascular lithotripsy from rock to metal. And these are my tips on the use of IVL. Balloon artery ratio should be 1:1 in long lesions. You might remember we're talking about real life cases, not the CAD3 cases, which excluded many of the real life cases, which we're now using IVL in. But philosophy remains that you size it to your distal part of the lesion, because we end up doing long lesions. In a number of times, we're actually rationalizing and rationing the 8 pulses, 8 cycles that we actually have, unless we want to take another IVL balloon, which is also okay, but it just costs money. And it costs money from all payers are reluctant to pay out that much of the money. And of course, therefore we have to optimize on the expenses. I would also urge you not to cross a tight calcific lesion with a balloon. It's a device, it's not a balloon. We must try and predilate the lesion and not feel guilty about predilating the lesion, because not just that it allows the balloon to cross, but if we emit pulses on an under-expanded balloon, we would actually emit pulses on the balloon material. And while you actually now have the C2, which is approved in the United States and more recently in Europe, the earlier generation of the the balloon, which was actually the ones we have at the moment, are prone to rupture, are prone to leak. And that is one of the reasons for their proneness to leak. They have been modified in January this year. And that's the balloon that you actually have in the United States and got recently approved in Europe. Give the balloon the time to deflate before activating the pulses. Wait for 20 seconds between cycles. Both let the vessel breathe, but there's also that you actually cool off the contrast material within the balloon as you withdraw it into the indeflator. That material cools off. Remember, there's heat being generated in that contrast saline liquid, which is inside the balloon. We have to end up delivering more cycles over eccentric and nodular calcification. We must remember that balloon expansion is the methodology for knowing that the lesion has been fully, should we say, shockwaved, and do not go beyond the pressures of the balloon. This is a nice case, illustrative case, how we actually have to combine technologies. This is obviously a circumflex, heavily calcified circumflex and LAD, and you actually have the circumflex that's rotablated and a stent implanted, so that's not a big deal. The LAD is for rotational atherectomy, but again, a 1.25 burr does not cross that mid LAD after even a 2 minute of burr time. Like I told you on my algorithm, I can upsize the burr, or I can just balloon it and then go back to the rotational atherectomy. That deflects the calcium where it was being obstructing the burr most, and then gets the burr most centered to the vessel. I do that, as you can see on the right side, with a 2.5 millimeter balloon at 20 atmospheres. I am able to then rotablate that area, and I go down to the mid LAD, but again, my burr does not cross the mid LAD lesion, and another 3 minutes of burring time. And then, of course, I then take a non-compliant balloon again, which bursts at 26 atmospheres. And of course, we can't image this vessel because nothing would go across and down, and therefore deliver the shockwave balloon partially across the lesion. So there are multiple ways. One has ways of doing what I call halfway rotational atherectomy, where you only halfway do the rotational atherectomy, then deal with the balloon. But in this case, the balloon bursts and is unable to open the lesion beyond where I've burred up to where I have burred, and therefore deliver the shock wave using a guide extension catheter. The shock wave then is, you just deliver the shock wave along the whole length of the lesion right up to the ostia of that vessel. And in real life, because I've only used one shock wave, I'm going to be undersized to the proximal part of this LED. I may be optimally sized to the mid part of the LED, but not to the proximal part of the LED. And therefore, I would then use maybe an ultra high pressure balloon for the proximal end of that LED. 2 stents are implanted into that. I think expansion was seen, and then ultra high pressure balloon at 35 atmospheres was done at the osteoproximal LED. You just saw that result. You see how big the vessel grows. It didn't look as big as this when we set out to do this. This is now a 3.5 millimeter vessel, what looked like a 2.5 millimeter vessel, and had a great expansion of the stent, including right up to the ostia, sparing the ostium of the circumflex. Accurate landing, I would say. So this is a complex case, again, from another center who tried to do an angioplasty to this vessel around 6 months prior to this procedure. They could do something to the mid lesion in the mid RCA. This lesion could not be approached or could not be dilated and was left alone. Patient returned back with a restenosis, instant restenosis in the mid RCA, and of course a lesion which was left previously in the distal RCA. This is a complex because it's upward going RCA, heavily calcified. You can't even know where the stent is and where the calcium is, but somewhere in there is stent and most of it is calcium. This is as best backup as you can get: long sheath, AL1 guide, Grand Slam wire, and a guide extension catheter. I don't think you get any more, and of course from the femoral. So you can't get more support than this to get down this vessel. A compliant balloon, of course, would not cross that distal lesion where they had failed in the other center. A microcatheter would not cross, but one is able to get a rotor wire, and one gets a rotor wire. I mean, the options, of course, if you can't get a rotor wire down, laser, which is what I would have done, but I've got a rotor floppy down, and therefore a 1.5 burr. And a 1.5 burr, I did get a 1.5 burr. And then, of course, an OCT demonstrated all sorts of heavy calcification, looking at circumferential calcification, deep calcification, thick calcium, long calcium, nodular calcium, as well as underexpanded stent with an in-stent restenosis. So, of course, it was shock wave all the way through, right from distal vessel all the way to proximal vessel. And again, like I told you, while I sized the shock wave to 3.5 for the distal vessel, I would have had to use another shock wave or a 4 millimeter shock wave from the proximal vessel, which I did not. I then imaged it again. I then used an OPN, ultra high pressure balloons at 40 atmospheres all the way along the vessel, and then got a good expansion of the vessel, followed by stent implantation, saw a residual stenosis in the proximal segment, imaged it, had a large MSA, was happy with that, and that's the final images of the OCT analysis. Therefore, but I think I've got 2 or 3 more cases. I hope that I'm not overstepping my time here. I think I have 4 or 5 minutes to say how to expand on some more complex cases. For example, the 77-year-old male. Again, you'll see that dealing with these has to be a combination of understanding the lesion through imaging and moving to complementary devices, which could be a combination of devices to get the final optimal result. 77-year-old left main bifurcation, extremely difficult entry into the circumflex calcified. I wanted to enter the circumflex first, as you can see, because it's close to 95% at the origin of the circumflex. On the other hand, I also wanted to rotablate as the safest way to deal with the ostium of the circumflex as well as the LAD. If I hadn't got into the circumflex with any wire, I would have rotablated into the LAD to try and get as much opening or the ostium of the circumflex to again pass and down the circumflex. But I did manage finally to get down the circumflex to various wires and then getting a microcatheter to the ostia of that circumflex and finally a rotor wire down. And of course, we must know that small burr, again, because there's a huge guide wire bias, and that guide wire bias helped me to get the ostium of the circumflex open. And then of course, there is a visual of, I again use a 1.7 for the burr for the LAD. And after having done that, I did IVUS on both those vessels. I did IVUS on both those vessels, demonstrated the fact that there was deep calcification, extensive and deep calcification. I had created grooves in circumferential calcification in the LAD, and it was clear that I was going to now move up to intravascular lithotripsy, a 3 millimeter balloon in the ostium of the circumflex that actually did rupture. And you can see the balloon leaking in the right side after 5 cycles. I then took another 3 millimeter balloon and did some more on that vessel. That balloon also gave way and had a leak. I moved up to, that ran out of 3.5 millimeter balloons. I used a 3.5 in the LAD. I would have liked to use a 3.5 in the LAD. I used a 3 millimeter in the LAD. For the distal part of the lesion, I then moved to the proximal part of the lesion, and that was again a 3. I was under for the 3, but I think the lesion had been adequately dilated. I did an IVUS on that lesion and decided to stent it at this time with a mini crush single kiss technique, as you can actually see here. Crossed it, recrossed into the LAD, a final kissing inflation with opians this time. Dilated sequentially at high pressures of 30 atmospheres at both ostia, and then a final kissing balloon inflation at 15 atmospheres with opian balloons. And then with a final pot, had a great result on that vessel. As you can actually see on the right side, carina central looked great. And that was IVUS images showing MSAs in the left main of 15.6 and in the ostia of the circumflex at 8.6 and then LAD at 7.6. So that was a good result in that. Perhaps just one interesting case, vein graft, severely heavily calcified lesion done at another center. And interestingly, this vein graft is an old vein graft. This was rotablated by the gentleman, the interventional cardiologist, another center. And I think, there was no, that's right. And this is that other center. This is a piggybacked graft also going to the circumflex, as you can see here. And this is again a heavily calcified lesion. So they couldn't get a balloon across. So they rotablated that heavily calcified vein graft. And then of course, a stent was placed, under expanded in multiple areas, that stent. At that stage, a non-compliant high pressure balloon dilatation was performed. The patient did fine. That's still at another center. But then he had a restenosis, got exacerbation of symptoms 6 months later. He has a new lesion which has developed. Well, he's got a lesion instant restenosis at the distal end of that long stent. And then there are other areas which are underexpanded. Well, there was another lesion distally which I treated, but that's not so important. But actually, this is so interesting to see the OCT. Of course, there was fibrointimal hyperplasia at the distal point where that high-grade restenosis had happened, but there were areas of underdilatation. There was nodular calcification at the midpoint, and there were obviously nidus for future events, should we say. So once I was treating it, I decided to treat the whole of the stent properly and appropriately, which had not been done. So after cutting balloon across this whole stent, I then proceeded to intravascular lithotripsy using a 3.5 balloon. And you can actually see that once that was done, and 8 cycles were delivered along the line. What I'd really like to show you is the nodular calcification. We know that these are very difficult animals to treat, but you saw that nodular calcification in that, and you saw that the lumen area at that stage, or I call it the MSA, was 3.4 or something. Well, you now have cracks and fissures, not at the nodular calcification, but by the side of it. And you can see that we're now getting better expansion. Well, at least with the IVL, we got some better lumens. But I love these calcifications which appear not inside but on the side, because then as one proceeds to ultra high pressure balloon and goes up to 40 atmospheres in that stent after having delivered IVL. And by the way, the only confidence we have of going up to such high pressures is because we know the sizing of that vessel by imaging. It would have been stupid to do this without imaging. And by the way, I've burnt my fingers having done 40 atmospheres without imaging and having had perforations. So this is only possible if you've imaged the vessel. Followed by a drug-eluting balloon after ultra high pressure balloon. And then, of course, a stent implantation at that focal point where instant restenosis had occurred. And we got a great result, a much better result, which on imaging is even more interesting, because now we've actually perhaps increased that area by 80% from a 5.4. We started off with a 3.5, increased it to 5.4 after IVL. And look what happens to the nodular calcification. It's flattened out primarily because we'd created cracks on either side of the nodular calcium. And now we've got a circumferential, mildly a D shape, but perhaps an oval lumen, but certainly close to MSA of 9. And these large MSAs perhaps would improve his outcomes in the longer term by a combination of technologies only on the basis of imaging. Can I have one final case? I know that I'm going to be, I said 45 minutes, but this is worth it. This case is worth it because this is a patient with previous bypass surgery, and the microcatheter would not cross that distal lesion in the right coronary artery. Obviously, they had bad angina, huge right coronary artery, and as it would not cross, I could get a wire across, and I said, okay, this is a case which I say I fitted into, oh my God, what do I do next? Because my algorithms of use of combined technology failed in this case. So our algorithms clearly state, okay, so if lesion, you can't cross a lesion with a balloon or a microcatheter, just get a wire across, rotablate it. And that's what it is, rotational atherectomy or ablation of some sort or the other, and then proceed along. But what happens if the burr doesn't cross? So I actually therefore went through, got a rotor wire across, and 1.25 burr would not cross after 3 minutes. So I said, okay, my strategy of ballooning it with non-compliant balloons and then doing more rotational atherectomy, but again, no balloon would cross it. And then I finally got a 0.8 millimeter balloon across that lesion, and it ruptured at 24 atmospheres, as you can see on the right side. So I said, okay, this is what happens next. I told you this, what happens if a burr doesn't cross, I told you. This is what I did. I did balloon dilatation, granuloplasty, nothing worked. So again, I have all these options to go. So again, go back, and this time I decided maybe I should actually take a larger balloon, a 2 into 28 millimeter balloon. Again, nothing happened. And I think I ruptured the shaft of the balloon. Whenever you see a sausage developing prior to the balloon, think that that's the shaft of the balloon rupturing. That dissected my artery right up to the proximal segment, as you can see here. I still haven't done anything to the lesion. Oh, I move across. What else? Ultra high pressure balloon for that lesion. Okay, let's take ultra high pressure balloon. I didn't have the laser at that time, which now I have over the last year, but I didn't have the laser at that time. I got it a month later from this case. So again, a 2 millimeter balloon would not cross an OPN, 1.5 millimeter would not cross. So I went back to the rotational atherectomy, and I went back to the rotational atherectomy with a 1.25 burr. And of course, after 60 seconds, I did get across the lesion. So I said, here, I'm on a home straight now. This is great. It's been burred. I went back with an OPN NC balloon. I had options of going with a larger burr or an OPN NC, which was already out there. Nothing. Ruptured at 45 atmospheres. The lesion still would not give way. I said, okay, a larger OPN, a larger burr. I had all that extensive dissection. I would need to take the burr down that curve. Perhaps I should get a guide liner down. I could have got my OCT done, understood the nature of the lesion, but really I didn't know what the nature of the lesion, what to find out. After all, it's a calcified lesion. I've got to find a treatment for it. I went with an IVL. The lesions go always anyway going to be concentric. That's why it's not giving way. 35, so that's a 2.5 OPN. At 35 atmospheres, it still doesn't open it up. At 45, it doesn't open it up. So I go to an IVL. That's my third one. An IVL, after 80 cycles, does not open up the lesion. So now I've run out of all my tools. I haven't got the laser. Okay, 80 pulses are still the same. Go back. More cycles, a larger IVL. Go back to an OPNNC. Keeping the cost in mind, I went back to a larger OPNNC, and look what happens at 40 atmospheres. After maintaining at 40 atmospheres, the lesion finally gives way, as you can see there. That was at a minute of 40 atmospheres. Of course, after that, one was able to implant drug-eluting stents all the way up to the lesion, up to the proximal segment, then assess that, make sure that you have the whole lesion, the whole vessel absolutely done. Final OCT analysis showed good expansion. It was calcified at that particular point, circumferential calcification with the nodules, and had and of course, good expansion all the way, and the final OCT showed a great result. So I think I'm going to end up in this, not to take you through too many of these cases, but I'll just take you to my final closing slide. My final closing slide is not to do with anything like this, apart from noise, showing you that you can rupture vessels by device synergy if you haven't imaged the vessel. This is another triple vessel complex heavily calcified case done on Impella with an ejection fraction of 20%, where I had 4 complications. But then I just want to come to my final learnings. What we've suddenly realized over a period of time, using multiple tools for treatment of real world heavily calcified complex lesions, is that the tools are complex, they're complementary, they're not competitive. And we certainly, as we get into more and more complex lesions, we need advanced algorithms beyond the ordinary, which only come because of our own experiences and of our colleagues' experiences, and of us getting together to share such cases where we can actually make algorithms beyond the ordinary, like what happens if a rotor burr does not cross, what happens if an IVL does not even fracture a skull concentric calcification, and so on and so forth. And then intravascular imaging, while we often emphasize that it's got such an important role in severely calcified lesions in terms of strategizing our tools and for optimization, but also importantly, it's the safety of the procedure. And intravascular imaging is extremely important for safety of the procedure when using multiple tools, including ultra high pressure balloon dilatations in these severely calcified lesions, in these very fragile and, should we say, complex patient subsets. Thank you very much for your attention.
Thanks, Ashok. I'm kind of speechless for from some of your cases, because they really, as usual, phenomenal cases. And I think that here in the Bronx and your practice in India, we share a lot of similarities. We see a lot of patients with very calcified lesions who require multiple devices. And I really appreciate also the fact that you showed, starting with rotor, when things can potentially go wrong, and how to recognize it, but also that these devices are not, the panacea. You think you have one device and it can deal with everything, that every device has its limitations. And so, having an algorithmic approach is super important. So, this is for the fellows. So I'm going to ask the fellows to start making their comments. As the fellows come on, I'm just going to ask you a couple of questions from the chat, and then I'm going to pass it on to Jesse that I see there. So one of the questions is, are there any particular subsets where laser helped you more than the other techniques for lesion preparation?
Absolutely. I think that's a great question. And I can actually say 3 of those. One of them is those very situations where a rotor burr doesn't find a purchase. And in those cases, laser is not your tool to get through that long, heavily calcified segment on a tortuous. Laser is a tool to break your proximal cap or give you that space to move away and the rotor blade for your burr to get more central and start burring through what would be a central rather than an eccentric cutting into the vessel. The second aspect is osteal lesions. There was a case out there which you saw briefly flashing away, which I went across, where in a situation which is heavily calcified, osteal CTO, where I did get the wire across, but my guiding catheter was not coaxial to the vessel itself and to the origin itself. And that would have been a disaster had I used a rotational atherectomy, but it was clearly, laser was very helpful in traversing into the vessel, into the ostia of that vessel, and therefore ablating that calcified segment enough for me to get balloons down to then optimize the vessel and implant the stent. So I think those are two important. Of course, in-stent restenosis, we know that's an important aspect of laser. So thrombus containing lesions are a very important aspect of laser. And I think those are that's why you saw in my algorithm later does appear for failed rotational atherectomy for those instances where you don't have situations of, or for that, so that lesion, which was very focal and which was undilatable. So short segments of undilatable or unrotablatable lesions would be my point.
Right. Then, another quick question, that early case you showed, which also made me so nervous. It was so tortuous. And you changed from 1.5 to 1.25. Dr. Menegas asks, do you ever pull back the rotofloppy wires so that you have the floppier part in front of you so that you have less bias? Do you ever do that?
No, I don't. I don't. In my 30 years, I don't do that. The important aspect is in that algorithm, you must change you can change the burr, you can change the wire to remove the bias, change the biases, but it's not a good idea, I believe, to bring back the wire. You must remember that the distal segment, the floppy segment, is a 014, and then the rest of it is just a taper. The wire has a long taper. You don't want to be in a situation where your wire doesn't support your burr when it actually crosses. So algorithmic wise, can I just say to you, 1.5 go down to a 1.25. If the 1.25 doesn't cross, you may change your floppy to a rotor support, but not at angulated lesions. At curved lesions, yes, but not at angulated, because you're just going to get more biases. And then if the rotor support doesn't provide you, then you go up on the burr size to one. Remember the ballooning. I actually would tell you that the halfway rotational atherectomy is something which must keep in mind, which means that in an angulated lesion, if you are not being able to get across that angle, don't force your burr to go across an angle. If you've done the proximal part of the lesion and there's angulation after that, and the lesion goes into the angulation, just be happy to have burred the proximal part of the lesion and then go back with a balloon, and just remember to do rest of the lesion with a non-compliant balloon. Because even if you partially ablate and crack calcium, those same calcium cracks may actually help you to break the rest of the lesion, because the lesion is a continuum. These are not separate bodies. Yes, they can have separate consistencies, but your proximal rotablation before an angulation can help you crack a lesion after an angulation with just balloon itself. So that's what I call a halfway rotational atherectomy. It's not, you're not losing, you're not, how should we say? Don't need to feel guilty about the fact that you didn't go across the whole of the lesion in an angulated segment. And neither do you feel the fact that the lesion has beaten you just because you didn't cross it enough.
Right. So I'm going to pass you on to our fellows who I'm sure are dying to ask you questions, Ashok. I see Jesse and Manav there, and maybe some of the other fellows want to turn their mics and cameras on. That would be great.
Hi, Dr. Seth. I'm Jesse, one of the interventional fellows here. Thank you for a great talk and great cases. I feel like I could just ask you questions for like 3 hours now, but I don't think we have time for that.
I could answer them for 3 hours as well, I feel. Yeah.
So yeah, I think my questions are more on the fine points of rota. I noticed that you used a lot of 125 burrs and pretty big vessels and proximate LADs. And I've read some chapters where they suggest that you really should be sizing the burr of 0.5 to 0.6 times the reference vessel. So one question I have is, how do you decide when you should be using a smaller versus bigger burr? And I think you talked a little about the angulation that you see in the vessel itself. And the other question is, you talked about switching to Rota extra support wire. When do you go up front with an extra support wire? Is it osteo lesions, or where do you actually start to go with that wire, and why?
Okay, so on the first question about, you saw the 1.2, the biggest caution around a 1.25 burr is that you should never push a 1.25 burr, because the greatest number of entrapments, burr entrapments or burr slipping through, happens with a 1.25 burr. The place where you use a 1.25 burr is tortuous anatomies. And that's why you saw that tortuous anatomy where it was downgraded from a 1.5 to a 1.25. Angulations, where you don't want to really have a large burr. And I'll also talk a bit more about that. And certainly branching points, when you come to branching, or distal small vessels. That's when you actually take a 1.25 burr. So if you saw some of those 1.25 burr, they actually fitted into that very issue of extreme calcification, tortuosity, angulations, and branching points. As regards, another point I've got to tell you is that, you remember my saying that if you don't get through a lesion after some time, you can upsize the burr. Not downsize it, you can upsize the burr if it's a straight segment. Or if it's not too angulated a segment. And the reason for that is, and I've actually had instances of that, where I've gone up on the size and been able to cross it. There are two reasons for that. Firstly, of course, that you may change away the bias of the wire as you take a larger burr. But also, the more important fact that you've got a larger ablating surface. If you see the 1.25, all it is a rice grain type of a burr. So it's got a great forward push, but it's not got a large ablating surface. So on occasions, if you're centered, you may be fine with a burr which is more conical, but you're not ablating, and that's the reason why it tends to slip through and have what we call the burr entrapment, and that's my biggest concern about a small burr. So I'd say that in my own practice, 80% of the burr, 85% of the burr is larger burrs, be a 1.5 and above. And it's only 20% or 15% which form the 1.25 burr. Sometimes as a part of downgradation and sometimes upfront. As regards Rota support wire, believe you me, it's only once or twice a year that one ends up using a Rota support wire. So it's one of the least used wires. It's least used primarily because it's a good wire for osteas, where you can actually move the wire, and firstly, you don't cut the wire, or you got the least chances of cutting the wire. It actually takes your burr to the ostia much better. You can have your guide out of the ostia, and therefore you can actually ablate a much larger area by moving your guide around the ostia, thereby changing the direction of the rotablator burr to the ostia. So and the only other area is that if you got one, if you want to straighten up an artery, which is reasonably large, but there's a sharp angulation in that artery, you can actually change the wire from the outer to the inner. So what will happen is that your softer wire, or when you say Rota floppy, may actually ablate the outer curve, and with your extra support, you may ablate the inner curve. So in a larger vessel with a smaller burr, you can get larger ablations if you change from a Rota floppy to a Rota support wire. So there are just two reasons to using a Rota support wire.
Right.
It can change your biases to a worse bias or even to a lesser bias.
Bob and Nikos?
Yeah, I have two questions also. One has to do with the imaging modality. It seems that from your first slides, it seems that you're favoring OCT. So is it safe to say that in this kind of complex lesion, since it gives us more information to characterize the lesion and pick our strategy, should we go with OCT instead of IVUS? And the second is, what's your experience about in some of those lesions with orbital atherectomy would work better depending on the lesion characteristics?
So the only tool we haven't got at the moment with us is orbital atherectomy. So that's why I've not commented on the tool itself in terms of heavily calcified lesions, and you all are better experts at orbital atherectomy. But the only thing I can say is the first in-human study of orbital atherectomy has my name because I was a co-investigator in that. That was used. That was, can you believe the study happened in India? And I was the co-investigator of that study. That's why the first paper has my name on it. But we haven't got the tool, and it'll probably be coming in the next 6 months. As far as your first question is concerned, therefore, which is on imaging, I don't want to be biased towards either. I think you need to use the tool you're best experts at, and each one of them has advantages which favors them. For example, you don't have to use contrast, and some of these patients are really have severely impaired renal function. But there's no question that the information about quantification of the calcium, the thickness of the calcium, is clearly been outlined on OCT, and therefore it provides you more information regarding the tools and strategies to use, and therefore I favor it for calcified lesions. Having said that, if you there are as you know that there's a scoring system already there for intravascular ultrasound as well. I just find that the scoring system and you can see calcium and quantification and depth much easier. And you can also see distal and proximal vessel optimization, algorithms for optimization, getting MSAs and large MSAs are easier in OCT than with IVUS. But you must remember that none of these have been prospectively, OCT has not been prospectively studied for outcomes in any of these lesions, including heavily calcified lesions. IVUS has data for both in terms of outcomes, in terms of mortality, and in terms of survival, and in terms of MSAs on an intermediate term, and in terms of MACE and intermediate term. So we've got to remember some of these aspects. I favor OCT, and in general, OCT gives us more information which can be easily utilized than IVUS. Does that summarize it?
Yeah, absolutely. Yeah.
Thank you, Dr. Ashok. My name is Bob. Just a quick question, more practical, about RotaShock and patients who really decompensate during rotablation. As a young fellow, you see this and you wonder if there are factors or predictors of certain patients that are more susceptible to this. Some operators say you should flush throughout the rotablation. I don't know what your practice is, or if this makes a difference, or what other things. Some of them may have no reflow, but a lot of them get bradycardic. Some of them look very sick. Is there anything you do in your practice with these patients, even in a non-RCA lesion, by the way? It doesn't have to be RCA. They still get pretty bradycardic. I wonder what you think.
So let's start from I don't use a flush solution, but flush solution are the one you have there.
We have Rotaglide over here.
Yeah, Rotaglide
in the US, but even in Europe, in Milano, we never used it. We flushed with heparinized saline.
Correct.
Yeah.
So we flush with heparinized saline. We don't have diltiazem or nitrates into our flush solution. We used to when we started rotational atherectomy, and Azim would remember that early days when we used to put it. But we must remember that we can actually overflush those, so we don't have those anymore. But what we do is three things which are very important in my mind. Firstly, that we make sure our pressures are above 100. You always keep pressures up when you rotablate, primarily because otherwise you will have greater chances of slow flow. So that's the first thing. Secondly, that while it is said that high burring speeds can get you slow flow, I always use at least 170 to 180 burring speeds for smaller burrs, and slower speeds of 160,000 for burrs of 1.75 and above. So that's the second point. Thirdly, that I frequently, during the procedure, at least 2 or 3 times, would give diltiazem and nitro into the vessel, which means I would just give it into the guiding catheter. So I won't use it in the flush, but I would give it into the guiding catheter. Fourthly, would limit my runs to 20 seconds to 25 seconds, max 30 seconds at a time, giving the vessel time to breathe and flow to improve and be TIMI-3 during this time. The moment I see a TIMI-T2 flow, I would make sure that I don't burr any further. I restore that flow back to TIMI3 flow before I start burring again. And even if that means giving nitroprusside, giving diltiazem, I would do that and make sure that I've done that. Finally, I would actually make sure that if I would never go in straight away in a long diffusely diseased segment with a large burr, even though if it was a large vessel. For example, it's a 3 millimeter vessel and it's diffusely long lesion. I would make sure that I just don't take a 1.75 or a 2 burr straight away. I would actually go with a 1.5, then upgrade myself so as to make sure that the debris is not large at any single given point of time to actually therefore create slow flow and no flow phenomenon.
Right.
If we follow these 5 points, I think we will do very well with avoiding slow flow phenomena.
I think that's all, great advice, and it comes from lots of many years of experience and many thousands of cases. Thanks, Ashok. Manaf, you had a question. Maybe you can do it live.
Dr. Latif, I do have some questions.
Samina, sorry, I didn't see you alive.
I do apologize. I have issues with my camera.
No problem. Go ahead, Samina.
Thank you so much for the great talk. I'm one of the interventional fellow. I really enjoy how you incorporate multiple different advanced technology in your algorithm, and I would really appreciate if you can share those algorithms with us later. I have basically 2 questions. One is in regard to IVL. What are the kind of red flags that you would avoid using IVL based on the patient anatomy and vessel? When would you be concerned using IVL? Is there any clinical scenario?
Not really. In fact, I think it's one of the easiest devices to use with the least amount of complications, apart from the fact that it's poorly deliverable. It's got a profile which is 0.35, 0.35. So it's like delivering a stent on occasions. It's certainly worse than a non-compliant balloon, and occasionally you just need to use a guide extension catheter to deliver it across proximal tortuosities. But on the whole, absolutely no other contraindications. All you need to do understand is that you have to size it appropriately, never fire it under expanded. It's a device you can't force through. And on the other hand, there's only one precaution that I would actually say, that's written in my editorial as well. You get shock topics. And I think you've started using IVL, and you see those shock topics coming.
Shock topics.
And CAD3 looked at that data very well, and there's not been any adverse events related to the shock topics, except that a recent report of ventricular tachycardia and fibrillation happening as attributed to the shock topics. I mean, obviously, when you do a coronary artery disease case and occlude the vessel for a long time, it's very difficult to say whether it happened because you were occluding that huge LAD and which caused VF, or was it the shock topic? But they correlated it to an R&T phenomenon. And therefore, I would say that you should be alert when using IVL. Not that you're going to be ready to shock people out of ventricular arrhythmia, but I think you should be sure that your defibrillator does work, that you're looking at that screen where the shock topics are coming, that you're not talking around and having a fun time in the cath lab, looking elsewhere, and that your techs are alert when you're actually giving the shocks to those patients because of the shock topics. Otherwise, I don't see a contraindication to the use of IVL.
Thank you. And my second question is more like a clinical question. In your center, doing all these complex cases with low EF, do you have a specific viability algorithm? Do you use any specific method for viability?
Okay, I'll come to the viability issue, but Samin, I think I wanted to address one more issue. On a number of occasions, I use electively either laser or rotor prior to shockwave. I already said that it's perhaps in almost all cases, I would pre-dilate the lesion before delivering the shockwave balloon, not just for the sake of delivery, but for the sake of the fact that I believe that a partially expanded shockwave balloon works better to deliver the acoustic pulses to the deep calcification. I hope you understand what I'm saying. If you've got a collapsed balloon and you start firing it, That's not going to get you the pulses well deep enough into the media, should we say, to the medial calcification. You've got partially dilated vessel, the balloon sitting well opposed, and therefore also the pulses are not going to fire on the balloon. They're going to fire into the saline contrast mixture, which is where you want those pulses to fire first. But the important aspect is that if on imaging I see an eccentric calcification or I see nodular calcification where my wire is actually towards that nodular calcification, which means my wire on which my OCT catheter has gone is towards that nodular calcification or towards the eccentric calcification, I would electively, not just balloon dilate, I would electively rotablate that lesion prior to IVL, even though I knew that I would be using IVL, because what it gets me is that nodular and eccentric calcifications are the weak spots for all tools, including IVL. But if your guide wire bias is towards the nodule or towards the eccentric calcification, perhaps atherectomy is your best tool, provided your guide wires are on that side. So when you do that, then if you use IVL, then you have to deliver less pulses to fracture the eccentric calcification. Otherwise, the amount of pulses needed to fracture eccentric calcification, maybe actually the whole of your cycles would be spent on that. And the same goes for nodular calcification, which is perhaps nearly impossible to treat by any other device, including IVL.
Thank you.
Great. Manath and Sharon, last couple of questions.
And then, no, there was a question on viability.
Yeah.
I use PET.
No, go ahead. You use PET. Okay, great.
Yeah.
Manath? We can't hear you, Manath. Unmute. Jesse?
Thank you for a great talk, Dr. Seth. One of the big takeaways I got from your talk is to never deploy a stent unless you're sure the balloon, which is size 1:1, can expand. But in those rare instances, for whatever reason, that you have an acutely underexpanded stent, what is your approach to try to salvage that kind of situation?
Manath, on the first point, I just correct that by saying that I didn't say 1:1. You know, when you use 1:1 and you use it at high pressures because you're cracking, you practically have dissections which spread forward and backwards. And you've seen that, you know, the lesion was there and suddenly you got the vessel dissected perhaps, and the stent would have been 18 millimeter and you now got a 28 millimeter stent in. So I use just a quarter size less, but I would go up to 18, 20 atmospheres, so that at 20 atmospheres or 22, what I'm getting is what I was optimally sized by angiography. So I'd say, you know, near optimal size balloon going up to high pressures, and that's my balloon test. But then coming back, because if you go optimal size and then you find that you're not dilating, that the balloon's not giving way at 16, 18, and you're going to higher pressures, you must also remember that your balloon, even though non-compliant, is also expanding. It expands less than a compliant, but at 22 atmospheres, you would have expanded by a quarter on a non-compliant balloon. So that's my first step to you. The second aspect is about, you said about underexpanded. The same thing happened to me. I didn't look at in two views exactly 2 weeks ago. Shockwave, LA cranial projection on a proximal LED, the shockwave absolutely looks, I've delivered now 50 pulses, 5 cycles. It's absolutely expanded. I didn't even deliver the remaining 30 because it was expanded. I put a stent, it looks great. I did an OCT, by the way, it looks good. I didn't notice the fact that after stent implantation, I just went to dilate the proximal edge of the stent in the ariocaudal projection, and lo and behold, it's 40% residual stenosis. When I look at the OCT after that, I have an elliptical expansion of an MSA, which was 3.8. And then I delivered the remaining 30 pulses inside. By the way, you must remember, in stent, under expanded stent with calcium outside, do not expect IVL. IVL perhaps is the only greatest tool for such situations, apart from creating granuloplasty with the laser, which you can actually do. But again, it's not off-label. But this is the easiest tool to use in such situations is IVL. But it's successful in approximately 70% of the instances in relieving that calcium outside the stent and getting you expansion. So therefore, you may actually end up using an OPN, ultra high pressure balloon, as an adjunct to IVL to get your full expansion if you don't get it with IVL alone. So for example, in that patient, I was able to only get some expansion from that. Non-compliant balloon did not give me an expansion, and OPN at 40 atmospheres increased that MSA in the underexpanded stent from a 3.7 to a 7.5. It was still elliptical. It was still elliptical. It was still not circumferential, but the MSA increased. And that I was pretty satisfied with that. So I think you got to be also cautious. You can't do these ultra high pressures, which you haven't got at the moment. But let's say a non-compliant balloon to 25 atmospheres after a shock wave for an eccentric lesion. You won't be able to do this unless you've imaged and are sure about the size of the vessel.
Yeah.
And that's an important aspect. So you now have a combination of IVL for underexpanded stents, plus minus non-compliant balloon, and I have it as plus minus ultra high pressure balloons.
Great, excellent. Sharon, did you have any questions? Maybe while Sharon's getting his mic on, there were just last two questions from the chat. Ashok, about granuloplasty. Generally, do you only use 1.25 or 1.5 balloons? What's the largest balloon you will intentionally rupture with safety?
Less than 1.25 balloons, okay. Always. You're not trying to create, you're just trying to create dissections into the lesion. You're not dissecting the artery. The larger you go, the greater chances of actually traumatizing the artery and the normal segment prior to the artery. When you rupture these very small balloons, you're just creating cracks and fissures into the lesion itself and not the normal vessel wall.
And then another question here. I mean, in all your cases, we saw Rota, we saw IVL, we saw OPN. I didn't see a lot of cutting or scoring balloons. Are you no longer using cutting and scoring balloons, Ashok?
Oh, I should have said that on the first slide. I think they're not bad devices, but I must tell you, I don't believe that they do. Firstly, of course, they're adjunctive devices, so you're correct. But they can't replace the devices that we've talked about, the ultra high pressure balloons, the rotational atherectomy or the orbital atherectomy, and neither the IVL. So I actually have them for mild to moderate calcification. They are my tools for mild to moderate calcification, not for severely calcified lesions.
Okay.
And that, of course, while the direct comparisons of these balloons have not been done, just yesterday, Eurointervention has published the ISAR calcium study or something similar, cactus or ISAR cactus, which actually looked at a comparison of the ultra high pressure balloon with the scoring balloons in severely calcified lesions, a randomized 75 patient study with I think 35 patients in each group, which demonstrated the fact that cutting balloons prior to stent implantation in severely calcified lesion would give you MSAs very similar to using ultra high pressure balloons prior to stent implantation in severely calcified lesions. Though they said that the angiographic results were better in the ultra high pressure balloons, I still got to read that. That was out as of today on my Eurointervention. So I still got to read that, but I read the conclusion. So what I'm saying is numerous studies have demonstrated that they help, but they're sort of, mild to moderate calcified lesions. I don't find that as at all a useful tool in comparison to the others we talk about in severely calcified lesions. And that's why you didn't see it, because I was demonstrating to you complex severely calcified lesions.
Okay, fantastic. We could carry on talking like this for another hour, because I have so many questions, and I'm sure the fellows do.
But you have a huger experience, or a huge experience yourself, Azim. You could have answered all these questions.
I love comparing notes and seeing what you're doing, and people I've learned from doing, because you're always learning in this job. I mean, you never know everything, and there's always something you can learn. So I've learned so much today, Ashok, from you again. So as Juan, so the fellows, thank you for this incredible experience. I think we have another lecture coming up with you. We can't wait. Thanks again. Have a great day.
Thank you very much. Great to be with you, and wonderful to talk to all the fellows. All of them are great. And I could have talked for a much longer period. Thank you all.
Great. Thanks, Ashok.
Nice to see you.